We'll go with the next talk by Dr. Mohit Dogra.
Thank you, ma'am, and thank you for the opportunity. I'm going to be speaking on retinal detachment with giant retinal tears. And since this was a complex RDK, session, I did not go down the route of actually telling you what a giant retinal tear is, how you conventionally would manage it. I'm going to just talk about 5 different aspects. So certain considerations which we might have in giant retinal tear patients. Some of them are not set in stone, some of them are controversial, some of them the jury is still out, but I still want to actually discuss some of those points. So I'm going to be starting with iatrogenic giant retinal tears and what we all should be aware of that, typically as we are surgeons, if you remove foreign bodies through sterile incisions, and any time you want to try and increase the size of the incision and use your MVR or whatever be your choice of instrument to get the foreign body out, you can get a port-side retinal, a giant retinal tear. Phacophragmatome, big boon for us for hard cataracts at the back of the eye. You can try and get them out, but please ensure that the vitreous is out because phacophragmatome does not have a cutter. So if you engaged vitreous with it, you can very well, with the high suction not realizing and maybe with the cornea not being as clear as you'd want to be, have a giant tear on the periphery. Anterior segment colleagues, or if you're doing combined surgery, fishing, going with all kinds of instruments to try and get your drop nucleus out, or some of our posterior segment, our anterior segment colleagues like to do a PAL, a posterior assisted levitation. By God, I hate it. I've actually managed more giant retinal tears because of this than I think one should. So if you do not know how to do any of these, only if you've seen them in conferences, please do not attempt them. If you're doing peripheral vitrectomy in endophthalmitis and you're going really gung-ho and you want to go all out into the periphery and do maneuvers as you would do in the reg RD, you're inviting trouble, and getting giant tears post-operatively is common. You can do, if there is something that we must be aware of, typically MIVS, big boon, 23-25 gauge cannulas, but if you have formed gel vitreous, especially in your main port, you can get peripheral vitreous along with some exudates, or in cases of vitreous hemorrhage, go into the trocar cannula, and then and sometimes, getting your instruments in and out can be difficult because the minimal space is actually taken by the vitreous that's gone in. And if you try and yank your cutter or whatever be your instrument out, you can actually cause the entire retina there to rip. And a case which generally has a good prognosis would turn out into something that requires a tamponade, maybe even oil. You can have port site in cases of interior PVR or cyclitic membranes where the pars plana anatomy is altered and it's entirely actually shrunk down. And if you want to enter at 2 or 2.5, 3 or 3.5 millimeters, there might not be any space, and you can go through the retina and cause a giant retinal tear or dialysis. And you can have misdirected cannulas, your infusion cannula, which is actually infusing into the subretinal space. And if you do not realize, it can keep ballooning up, and you could, sometimes, just land up with a giant retinal tear. I'll also like to show 2 small videos of what could happen. This patient had a traumatic nucleus drop, was planned for a combined lensectomy with and a glued IOL. So this is in prep for the glued IOL. So the flap on the right was actually well made. The one on the left wasn't quite as well made. It actually, the depth was fine, but while dissecting, as you will see now, if it's visible there, yes, you can see that, one's gone all the way into it's gone full thickness, and there is exposure of the ciliary body with the knuckle of the vitreous coming out. And while there was prep going on for the IOL, you can see that there is such a big stream of fluid coming out that at the port site, you can also see the change in reflex because there's a giant tear happening there. So a rookie mistake, but something that can happen and which could jolly well have been avoided from the get-go, and you can see that's a giant retinal tear there. This is another patient, was actually ophthalmos, and you can see that there was actually 17 millimeters corneal diameters, was planned for a lensectomy, vitrectomy, and retinal and actually RD surgery. After lensectomy was done, you'll see that the residual anterior capsule will soon be attempted to be removed with a forceps, and while pulling, and this has been slowed down, you'll see that because here the anatomy is altered, ophthalmic eye, differential growth. You have zonules which are inserting all the way posteriorly up into the vitreous base. Not only was the anterior capsule removed, it actually led to a giant retinal dialysis there. So please watch out in these eyes. These are all causes and all things that we can avoid. This is iatrogenic, giant retinal tears, some of which we can avoid and we should be mindful of. As far as GRD prophylaxis is concerned, I think fellow eyes of non-syndromic giant retinal tears, one must laser white without pressure areas, lattices, holes, and tears. Fellow eyes of syndromic giant retinal tears, at least that's what I do. I tend to follow the Manchester protocol. I laser 360 degrees from aura to the equator, one burn width apart, so all the way across equator to aura, 360 degrees. You treat both eyes of genetically confirmed sticklers type 1, type 2, and again, this is to prevent giant retinal tears and hopefully retinal detachment in both eyes in families in which sticklers is known. And you can also try and look at a broad encirclage as prevention. Mind you, if you do want to go down that route, a mere 240 band will not suffice because you need a broader indent, so a 220 or a 242 widely, and this is to prevent and counteract from the exterior actually contraction of the vitreous base. This is again just one case. This patient had a giant retinal tear in 270 degree, which was fixed. The fellow eye underwent prophylactic 360 degree aura to equator laser and was confirmed, of course, later. Was confirmed to have sticklers, and only then was prophylaxis done. But prophylaxis is a must because it's been shown that it reduces the rates of giant retinal tears in the fellow eyes to almost to less than 3%, as opposed to 50% in the natural course over 5 years. As far as encirclage, so typically not recommended in giant retinal tears with greater than 180 degrees. It can be considered in patients where the lens is clear and you want to try and preserve it and not combine it with either lensectomy or cataract surgery. I definitely try and do it in pediatric and syndromic eyes if it's 180 degrees and lesser, and for fellow eyes in stickler syndrome patients. I'll just show two patients here. This is a young boy, actually one-eyed, came during COVID, had a nasal 180 degree giant tear, and a broad element has been put, as you can see, and was actually managed with that for a high buccal indent syndromic patient. The other, again, he was a known patient, he was a known family history was there, the known stickler syndrome, had a fairly good prognosis, just macula off, giant tear, small giant tear about 100 degrees, was managed with gas actually, and but again, to support that, and because I wanted to put in gas, a broad element was put in these cases. So it's not something that should completely be put into the bin, but should be used in patients of syndromic giant retinal tears, pediatric patients, and also in patients with giant tears 180 degrees and lesser, especially if the lens is clear and needs to be preserved. As far as posterior vitreous detachment is concerned, as was also shown by Mahesh sir, conventional teaching states that PVD is present in GRD. Yes, for the most part, but please don't assume or presume it to be there, especially in traumatic posterior giant tears, because there the pathology is there was trauma and the retina was just cut like that. So there was no time for the vitreous to get separated. And in pediatric syndromic giant tears, as Dr. Mahesh had shown. And if you have that, again, as Sir actually showed, these progress and they don't do well with just a single primary surgery, and a lot of times will require very meticulous, time-consuming bimanual dissection to try and get the hyaloid off. And if you're unable to induce PVD in giant retinal tears, which you might in these, in this subset, a wide ILM peel should be done. Easier said than done, but can be done under PFCL. Just ensures that you can try and remove at least some semblance of hyaloid and do a short-term PFCL tamponade with a planned resurgery within the next 1 to 2 weeks. Just going to show, skip the video and quickly show another, a patient like that underwent what seemed like routine surgery for a giant tear, and presuming that the hyaloid was off. It wasn't. 2 weeks later, you can see that's the edge where the laser happened. The entire thing's contracted. There was subretinal PF. I'm going to skip the video for the want of time. And finally, the huge membranes were removed. Just goes to show that if you do that, please do not presume the presence of a PVD in giant retinal tears, as was previously thought. You must try and stain, and for the most part, you will have a PVD, but not in all. And in cases that you do not induce a PVD and you put in oil, they come up with very bad, very aggressive epi and subretinal PVR, with a more extensive surgery required the second time around. As you can see here, this is a traumatic posterior giant tear with with the impact site, and you can see the entire retina has actually crumbled crumpled up there, and no, PVD at all, because the etiology is trauma and not the separation of the vitreous. And you could, we could open the eye, the pucker up, and this patient did fairly okay. But just to show that, please do not presume posterior vitreous detachment in all, giant retinal tear patients. And I'm going to finish with this one slide and not show the other two cases for want of time. PFCL, big friend, we don't have to lie on our back, and the patient doesn't have to be suspended up in the air and us to do all these gymnastics to try and fix, giant retinal tears. Now, heavy liquids, big boon, completely revolutionized, giant retinal tear detachment surgery. It can also be used as a short to intermediate term, tamponades, as Dr. Raja might say, even as sandwich technique for time immemorial. My take on that is not as favorable as his. However, you have to be mindful of it going under the retina, of you causing high pressure, of you causing it to actually go under the retina and actually have. Again, this patient was referred to me from Delhi. Just going to finish with this. Bilateral, the right eye was fixed in one of the leading centers here. The left eye had a detachment, and this was, mind you, right after the legendary Dr. Steve Charles actually had given his lecture on use of short-term PFCL for giant retinal tears. And someone who was, I think, way more smarter than he or she thought he was, actually went about putting in a PFCL tamponade for a superior giant retinal tear. For my mind, the only contraindication, the only reason, the only patient that you should not be putting it in, and that's what you saw there. So you have PFCL filled eye, which is in front of the retina, behind the retina, and the superior giant tear, which could jolly well have been fixed conventionally, now actually ended up requiring a more extensive surgery, retinectomy, and whatnot. And as you can see there, also sutures for trying to retain silicone oil at the back of the eye with very poor, functional outcome at the end. So please, if you want to try a new technique, if you want to try and use PFCL as an intermediate term tamponade for giant tears, not for patients who don't have PVR and have a superior giant retinal tear. Definitely not for them. Thank you.
So, very good videos. What is your personal take on band for support for a GRT? And do you do cryo sometimes if you feel that the laser you may not get burns sometimes?
Yes, absolutely, ma'am. So I'll answer the second part first. So I actually cryo the horns generally, ma'am, in all patients with a clear lens, in which I'm not sacrificing the lens. I do not want to try and go all the way up, into the periphery, even with external depression with laser. So I will laser the rest of the part, but the two horns of the giant tear I will cryo. Yes, as far as a low indent or a high indent band is concerned, depending on what the case is, for all patients of 180-degree and less, extent of giant retinal tear, I put in a low 240, a low height, 1 millimeter height 240 band, and that's the only time I actually measure my 240 band, and I don't tend to, because I want a 1 millimeter height. For all syndromic giant tears, ma'am, I tend to look at a broader element, again, depending on what the extent is. And typically, the idea is to, because I presume that I will not be able to do a great job removing the vitreous as I will be in non-syndromic eyes. So I want to try and, support the edges, and if it's not too posterior a giant tear, even the edge of the giant tear with a broader element. But otherwise, for your myopic, for elderly, for traumatic anterior giant retinal tears, no band.